So starting with the next chapter of general pathology, and that is neoplasia. Well, a chapter which is not very much liked by a lot of students, and purely because of the reason that it has a lot of cramming up involved. But let me tell you, and not because I'm a pathologist and I'm saying that, but this is one of the golden chapters that we have in this subject, and you will realize the importance of this chapter right at the end of the subject. Because what do I mean by neoplasia? Means all the cancers, all the tumors in general. So right now you might feel that you've not read systemic path and it's sounding all Greek at this point of time, but eventually when you read all the tumors in all the different chapters and come back to this chapter, you will feel that this is a very nice summary, golden point, bulletized chapter for all of us. So yes, on that positive note, let's begin with this difficult chapter, and let's first start off with knowing that what is the basic definition of neoplasia. So if I try and divide it, like I said, if I talk about neoplasia, let's divide it into neo, because neo refers to new and plasia refers to growth. So this is basically a new growth, and in simple words, this is referred to as tumors. Now, whenever I say tumors, I necessarily don't mean that we are talking about only cancers. It could be non-cancerous tumors also. So it's very important that the first thing that you understand are the parts of a tumor. For that, let us quickly draw. For example, these are all the T's that I'm writing over here. These are all the tumor cells, right? These are all the tumor cells that you have. And now just imagine if, just forget a tumor for a minute and just think of, for example, there's a bacteria or a virus or a parasite that is coming into our body. Now what do? Don't we make antibodies? Don't we show a reaction? Of course. So now when a tumor is growing into our body, why would we keep quiet? Of course we are going to show a reaction, and this is the reaction that we show. Can you see these blue fibers that I'm drawing? So basically this is referred to as the fibrous stroma. So this first question, there are 2-3 very classical questions that come across this fibrous stroma. So first question is that who has made it? We have made it. This is not something made by the tumor. This is something made by us. So this is a host response, point number 1. Point number 2, that this is given a fancy name, and that is known as desmoplasia. That is known as desmoplasia. Okay, having said that, moving on to the next, what is it going to have a clinical implication? Now we are obviously moving towards more clinically integrated questions. So this is going to result in a hard consistency for the tumor, guys. And now I'll tell you how you're going to apply this knowledge to the surgery aspect. Whenever you go into surgery wards and you go into your first day of palpating a lump, doesn't the surgeon always tell you that either the lump is going to be soft to firm or the lump is going to be hard? When you touch a lump, when you palpate a lump, either it's soft or it's hard. And what indication do you get out of it? That if it is a soft or a firm lump, it is a non-cancerous, benign kind of a tumor. And if it is a hard lump, then probably it is a cancerous, or in other words, you can say it's a malignant kind of a tumor, right? Now tell me that how do you analyze this softness and hardness with desmoplasia? Because think logically, if it is a cancerous tumor, if it's a malignant tumor, would you create more response? Of course, cancer grows aggressively. So I am going to create more response. That is the reason that I am going to create more of desmoplasia. I am going to create more of this fibrous stroma, as a result of which the consistency will come out to be hard. On the other hand, if I have a not so cancerous, a benign tumor, this means the fibrous stroma production will be lesser. This means desmoplasia is lesser. This means the hardness is also lesser. That is how you analyze. So more aggressive tumor, more desmoplasia, more hard. I hope you've understood how the surgery and the pathology can be correlated, right? Okay, so finally coming back, what are the parts of a tumor? Number 1, they are the tumor cells, and number 2, it is the fibrous stroma, which makes the tumor very hard. And fibrous stroma, PYQ, it's a host response. We make it. On that note, please remember there are 2 tumors which are mentioned in Robbins which are known to show maximum desmoplasia. When I say maximum desmoplasia, I automatically understand that the consistency is going to be hard. And those 2 tumors are pancreatic adenocarcinoma and cholangiocarcinoma. I'm sure you've heard of pancreatic adenocarcinoma earlier also. And in case you are a new kid on the block in second year and you don't know what is a cholangiocarcinoma, cholangio word means what? Cholangio word means bile duct. So basically, this is a cancer of the bile duct. That is cholangiocarcinoma. These two tumors have been shown to have maximum desmoplasia. Now you know what is desmoplasia. It's the fibrous response. On that note, let's begin with the next introductory portion of neoplasia, and that is going to be classification. So you can see there are 4 varieties into which we classify it: benign, malignant, which you most commonly hear of, and then you have teratomas and mixed tumors and all that. So yes, I'm going to start my journey with benign versus malignant tumors, and we are going to start with the terminology. When we talk about benign tumors, there's a very famous suffix that is added, and that is going to be oma. Oma word is added, and that is going to be a benign tumor. So let us come up with some examples. For example, I use the word lipoma. So what is the word oma? Oma refers to benign. It's a benign tumor. And what is the meaning of the word lipo? Lipo means fat. It is a benign tumor of fat. If I use the word fibroma, again, what is the meaning of the word oma? Oma means a benign tumor, and fibro means of fibroblasts, or fibroblast or fibrous tissue. Okay, let's pick up another word. For example, we use the word osteoma. Again, osteoma means benign, and benign tumor of what? Benign tumor of the bone, osteo. Now these were common sense. Like if I say chondroma, chondrocartilage, so benign tumor of cartilage. Now let's make you analyze something which doesn't sound exactly what it is like. When I say adenoma, please remember, oma obviously means benign tumor, but adeno word means glands. So the name of the word or the meaning of the word adeno is going to be glands. So adenoma is a benign tumor of the glands. Let me give you some examples. Where do you see an adenoma? You must have heard of gastric adenoma, intestinal adenoma. These are the places where glands are present. These are the places where glands are present. So stomach has glands, intestine has glands. So gastric adenoma is going to be the glandular etiology, right? Okay, having said that, now I'm going to tell you the difference between something which you hear very often but you don't put too much of brain into it, and that is what? That is something known as papilloma. Now I just taught you what is the meaning of the word papilloma. Oma means benign, and you often can confuse it with something known as a polyp. So let me tell you what is the similarity. Both have something to do with P, papillary. So both of them are going to have these kind of papillary or finger-like projections. That is what is common. What is common to them? Both of them are going to have finger-like projections. Then when will I use the word papilloma and when will I use the word polyp? Remember, papilloma will be used whenever we are talking about the surface of the body. And polyp will be used whenever I'm talking about the internal organs of the body. So tell me something. If you had to call it intestine, internal organ, will you call it an intestinal papilloma or an intestinal polyp? You must have always heard of intestinal polyps only, right? So yes, the best example over here is going to be intestinal polyp. Very famous question that you get in surgery also. Intestinal polyps are very, very important. Similarly, on the surface, for example, you say something's on the skin. Skin is the surface of the body. So what would you want to call it? Would you want to call it a skin papilloma? So simple as that, guys. Anything that occurs on the surface is going to be more like a papilloma. Anything that occurs inside is going to be a polyp. Both of them happen to be benign. Now, till now, there's another question which has created a lot of confusion amongst the students, and that is, do I use oma word? Because if you realize, what are the things that I've told you? Lipo, fibro, osteo, chondro. Am I using the oma word only to the mesenchymal tissue? Most of the times, yes. Because if you open Robbins and read, oma is the word given to benign mesenchymal tumors. Means what is the other set of tumors? The epithelial tumors are not being included, although I don't personally think this is too correct, because adenoma is an epithelium, gland is an epithelium. But still, if you ever get an MCQ in which you are asked, oma word is used for benign tumors, yes, but which kind of benign tumors? Benign mesenchymal or epithelial? Mesenchymal will always be a better answer. Now, once you've done the rule, it is very important that you do the exception. So what was your rule? The rule was that anything with the word oma is going to mean that it is a benign tumor. Whereas when I talk about the exception, now I'll tell you, have you all heard of lymphomas? Of course. So lymphoma is what? It is a lymph node tumor, but it is not benign tumor. It is a cancer of the lymph node. This is an exception. Okay, next, all of us have heard of melanoma in the skin. Of course, it's a skin, but it's a skin cancer. It's a misnomer. The oma doesn't mean benign. All of us have heard of a testicular tumor called seminoma. Again, seminoma is going to be a testicular cancer. It's not benign. Similarly, you've all heard of the very famous one in testis. So let's come to one in the ovaries also. Teratoma, right? Teratoma again. Teratoma has the word oma, but it can be cancerous. And I'm using the word can be cancerous. I'll explain that in a while. But what I want to explain over here is something called chloroma. Again, chloroma has the word oma and everyone believes it might be benign, but it's not. So remember, lymphoma, melanoma, seminoma, teratoma, chloroma. These are some omas that you will read eventually which are not benign. But what is a chloroma? Let me tell you for the time being in a quick brief review. Have you all heard of a blood cancer called acute myeloid leukemia? Blood cancer, acute myeloid leukemia. Leukemia means blood cancer. The cancer cells should be present where? The cancer cells should be present in the blood. It's a blood cancer. But over here, this blood cancer has come up somewhere in the tissues. It has come up in the soft tissues. That is what is a chloroma. Repeating, what is a chloroma? When the blood cancer has occurred in the soft tissue. So they ask you which is the most common soft tissue. And remember, the most common soft tissue is the orbit. The most common soft tissue is the orbit, which means that my patient is most commonly going to present with which symptom? The most common symptom is proptosis. So these are some classical questions that you guys get when you're talking about a chloroma. Number one, what exactly is it? It's a leukemia. It's a blood cancer, but it has occurred where? It has occurred in the soft tissue. And which soft tissue? Orbit. If it has occurred in the orbit, it's going to push the eyeball forward. So that means there is going to be proptosis. Now, these are all the exceptions. I hope everyone's clear with the benign tumors, because we are going to move forward and talk about the malignant tumors. How do we divide the malignant tumors? They are divided into two categories. One kind of cancer, in simple layman term, if I say malignant tumor means cancers. Cancers are of two types. One is a carcinoma and one is a sarcoma. Carcinoma and sarcoma are the two types of cancers that you're talking about. So when do I use the carcinoma word? When the origin has come from where? When the origin has come from the epithelial tissues. When it's come from epithelial tissues, I call it a carcinoma. And when the origin has come from a mesenchymal tissue, I call it a sarcoma. If it's come from a mesenchymal tissue, we will call it a sarcoma. So let's understand this with the help of certain examples, right? When I talk about, for example, any epithelial tissue, I will mention to all of you. So I take the example of squamous epithelium. What will you call it? Squamous epithelium means I want to use the word carcinoma. Squamous cell carcinoma is the word that I will use. Similarly, you say that I'm talking about transitional epithelium. Transitional epithelium is an epithelium of what? Urinary bladder. So if I'm talking about transitional epithelium, it is transitional cell carcinoma, which is occurring in the urinary bladder. Similarly, if I have a cancer of the glands, what will I use the word? Adenocarcinoma. So this is common sense. Carcinoma I know is a cancer. Adeno word we all know means glands. So this is a cancer of the glands. Okay, coming to now the sarcomas, life is going to be simple. Now you have to think of all mesenchymal tissues. Okay, so if I use the word bone, what will you call it? You will call it osteosarcoma because it's a mesenchymal tissue. If I use the word fat, you will call it liposarcoma. Again, if I use the word cartilage, cartilage is a mesenchymal tissue, so you will use the word chondrosarcoma. So simple, guys. Whenever a mesenchymal word comes, we use the word sarcoma. But now comes a twist in the story, because what if you're dealing with muscle? And for that, I would definitely want to give you a separate data on it, because this is creating a lot of confusion. So tell me, when you're dealing with muscle, you call it myosarcoma, right? Because sarcoma means that it's a cancer, and it's a cancer of what? It's a cancer of the muscle. But now they want you to tell them, is it a skeletal muscle cancer or a smooth muscle cancer? So now, if in this muscle they write the word leiomyosarcoma, if they write the word leiomyosarcoma, so you know, okay, it's a cancer, you know it's a muscle, but you know it's a smooth muscle cancer. It's a smooth muscle cancer. Whereas on the other hand, if I use the word rhabdomyosarcoma, again, look at, split the word, guys. Sarcoma means cancer, myo means muscle. So which muscle? Rhabdo means skeletal muscle. Rhabdo is going to be a skeletal muscle cancer. I hope everyone's okay with it. These two words are very, very important. Leo word is going to mean smooth and rhabdo is going to mean skeletal. Coming back, we are done with our carcinomas versus our sarcomas. So going back to your classification, you had number 1 benign tumors, number 2 malignant tumors. Now we come down to the third category, and that is a teratoma, which you all have heard of, but we are going to study it in detail. When we talk about a teratoma, guys, please remember the definition of a teratoma says that it is having minimum 2 or more than 2 germ layers. This is the basic definition, although now this definition says that even one germ layer can also be a teratoma, but for all practical purposes, remember the basic is 2 or minimum 2 or more than 2. So what are the germ layers? Firstly, tell me. Go back to your embryology. We have something called ectoderm, we have something called mesoderm, and we have something called endoderm. Ecto, meso, endo. Do you all remember these as the 3 germ layers of the body? Yes. Minimum how many should be present? Minimum 2. So let's do the classification. Teratoma can be divided. You know, how do we always divide tumors? We always divide tumors into benign and malignant. I have the word teratoma having oma. So when oma comes to my mind, benign comes to my mind. But I also remember there was a list. You will say that ma'am had given us a list where teratoma, she had told us, can be benign or malignant both. It can be may or may not be cancer. So basically, teratoma is going to be that situation where either it can be benign, or it can be malignant. But that is not how you terminology does not go like that. For teratoma, you call it a benign is known as a mature teratoma and malignant is known as immature teratoma. So again, there are 2 terminologies that you're going to use and you need to do justice to them. Remember, this will help you a lot in gynecology. Repeating, when we say something is mature teratoma, it's having all the benign properties. Immature, having lots of M's, immature teratoma is going to be the malignant properties. So now, let me ask you, if they say, let me give you a scenario. If they say there is mature, everything, mature tissues are present in an organ. Like, let's say you're talking about ovarian teratoma. Okay, mature hair, mature skin, mature brain, mature GIT, all these mature tissues are there. You will label it as a mature benign teratoma versus they say immature neural tissue is noted. You will call it an immature malignant teratoma. Please remember there is a variant which everyone is very, very fond of. This mature teratoma, what am I going to do in it? So again, I hope everyone's heard of something called a dermoid cyst. Have you heard of it? Very, very famous question. So what is a dermoid cyst? If I ask you the definition, you will say it is a benign cystic teratoma, and now you will understand, and I'll show you a picture also. It's known as a benign cystic teratoma. Teratoma, I understand, we've just read it. It's going to have all the different germ layers. Benign means which category is it coming under? It's coming under the mature category, but what's the difference? It has also become cystic. That's the difference. Have a look at this picture, guys. I'll tell you the orientation. This is actually taken from the ovary. This is an ovarian specimen that has been performed or surgery has been performed, and inside it I can see a tuft of hair. So definitely I don't expect a tuft of hair to be present inside any organ unless it is a teratoma like hair, or maybe you can see teeth or you can see bone. All these kind of tissues will tell me it's a teratoma. Okay, so now also I realize, so I know that okay, hair is mature tissue. I understand that this must be a benign teratoma. Everything is benign, everything is mature, so this must be a benign teratoma. But also I see that there is a cavity. Can you see? This entire thing is a cavity. It's like a hollow area. It's not totally complete solid. It's a hollow area, right? So that basically means that this is not just a benign teratoma. It is a benign cystic teratoma, right? And now this is what you call as a dermoid cyst. But does that mean that once benign, I can never have a malignant version of it? No. Can you all notice in the bottom, if you notice carefully, there is one area which is nicely very solid and hiding at the bottom. What is this area? This area is known as the Rokitansky protuberance. This area is known as the Rokitansky protuberance. So, I'll share a personal experience with you, and that way maybe my experience will help you learn this. So I'll share an experience of what happened during the first 2 days of my residency. I got up, I had just entered my pathology residency, and we have a station in every path lab where whatever specimens, like this specimen came from the gynae department, something similar to this, and we have to cut through it and we have to analyze it and make slides out of it. So, it was my first 48 hours in the department, and obviously I only had all book knowledge at that point of time. I had also read this in my MCQs that fine, you will see something cystic, you will see a tuft of hair, you will call it teratoma, and I was like, okay, wow, I made a diagnosis, and obviously it's a proud moment. But so I put out a little bit of sections from here, I gave it, and I got slides prepared. But next day, when there was reporting, when our head of the department came, and immediately he said, show me the form, and he said, who has done this grossing? And I was like, sir, I was feeling very proud that I have done this grossing. So then he said, okay, very good, you mentioned about the hair, you mentioned about the cavity, did you see any Rokitansky protuberance? I said, yes, I have mentioned, I saw Rokitansky protuberance. He said, what did you do after it? Was it an MCQ? But then I told him that I didn't do anything, I just saw it and I mentioned it, that Rokitansky protuberance seen. So he said, it's not a showpiece. And that is how I always remember it. Rokitansky protuberance is not a showpiece which you see and just ignore and just write it that yeah, it's seen. You have to cut through it. And that is when I realized how practical knowledge is so much more essential than just reading textbooks. You have to cut through it. You know why? Because maybe there is a cancer hiding somewhere over here, may or may not be there, no one's certain. So you will have to cut through it and look at what it's like, a treasure hunt. You'll have to cut through it, you look at it, what is inside it, and then you'll find out that is it genuinely a benign tumor or can it have a malignant potential? So it can. So I always remember that line. And this is, these are minor things which you always learn from your journey of a resident, that these tiny little taunts that you will get from the seniors in your department, but they go a really long way. Until date, whenever I look at a teratoma, my eyes always take me towards a Rokitansky protuberance. Having said that, yes, coming back, so teratomas are of two types. We have a mature teratoma and an immature teratoma, right? Everyone's understood. Let's move on to the fourth variety. So what were the three types of tumors? Benign tumors, malignant tumors, teratoma. Now I'm going to go on to the fourth variety, which is a mixed tumor. What do you analyze by a mixed tumor? Please remember, I'm going to have a mixture of a lot of things. So the first example that I'm going to give over here is a very, very famous question that you have in surgery or in ENT also, is a pleomorphic adenoma. Have you ever wondered what is the other name of a pleomorphic adenoma? Pleomorphic adenoma is also known as a benign mixed tumor. It is also known as a benign mixed tumor. So let's analyze. Firstly, tell me, pleomorphic adenoma is a tumor of which organ? It's a tumor of the salivary gland. Which is the most common salivary gland that you have in pleomorphic adenoma? That is the parotid. Very, very famous question. It is going to occur in the parotid gland. Okay, having said that, why did you call it benign mixed tumor? Firstly, benign because it's a benign tumor. Okay, very good. I'm happier. Whenever a tumor is non-cancerous, benign, I'm happy. But why did you call it mixed? Why have you put it under mixed? Because it has a double composition. It has epithelial component also and mesenchymal component also. So it's going to have epithelial component, and I'll tell you, see, that is why you got the first name also. Epithelial component, that is why you called it adenoma. Adenoma means that is going to be the epithelial component. And why did you call it pleomorphic? Because it has pleomorphism means it has different other things also. It has mesenchymal component also. It has mesenchymal component also, means what does it have in the mesenchymal? It has cartilage. It has chondromyxoid stroma. It has chondromyxoid stroma. Right? So having said that, let's do a repeat. What is a benign tumor? Of course, it's benign, good for us. Mixed means it has a double composition. It has epithelial and mesenchymal. Epithelial means it has that adenoma, glandular part. And mesenchymal means that it has a little bit of cartilage in it. That is one example. But did you notice this was benign? Now I'm going to tell you a little bit of a malignant mixed tumor. And that is going to be a very famous tumor that you study in pediatrics. That is a Wilms tumor. Now, what is the other name of Wilms tumor? That will make a lot of sense. Wilms tumor is also known as nephroblastoma. Wilms tumor is known as nephroblastoma. What did you analyze from it? Nephro, it means it's a tumor that occurs in the kidney, of course. But did you ever notice why did you call it blastoma? Because please remember, this is also a mixed tumor, and this time this is going to have three things. What mixture? See, pleomorphic adenoma had what? Epithelial component, mesenchymal component. So Wilms tumor also has that. Whenever there's a mixture, there will always be an epithelial component and there will be a mesenchymal component. But what is extra in a Wilms tumor? That is why, did you notice I called it a blastoma? Because it has a third very important component called the blastemal component. And as a result of which, it has three things. Epithelial and mesenchymal, every mixed tumor is going to have. The third most important thing is blastemal. Because it has three things, do we call it famously as the triphasic tumor? It's very famously known as the triphasic tumor. So repeating once again, there are two mixed tumors that I've taught you. One mixed tumor is totally benign, occurring in the salivary gland, the parotid gland. The other is a malignant mixed tumor which is occurring in the kidney in kids. Kids' kidney is going to occur. It's a very common childhood renal tumor and it has three components. Because it has three components, we call it triphasic. That wraps up our entire classification. But before we wrap up this topic, there are two miscellaneous terms that I want all of you to know. These are away from the classification but will definitely get you a question. One of them is known as a hamartoma and the other one is known as choristoma. Before I start off with their details, let me tell you one mnemonic so that it becomes a little easy for you. What is hamartoma mnemonic going to be? Everything is going to be hamara. In hamartoma, everything is going to be hamara, whereas in choristoma, everything is going to be chori. That is how you're going to learn it. Hamara means mine and chori means stealing. Okay, that is what we are going to study. So let me start off with the first one. Let me start off with hamartoma and I will explain this with the example of a pulmonary hamartoma. You know, hamartomas can occur many places in the body, but let's understand this with an example. So first and foremost, you will ask me, what is a hamartoma? Oma means what tumor? Benign tumor. So is hamartoma a benign tumor? Yes, it is. Hamartoma is a benign tumor, number one. So, you know, if you read the old books, if you read 2-3 prior editions of Robbins, it was not considered as a tumor. They said that it's not a tumor, but now they say there are chromosome 6 issues, there are chromosome 12 issues, 14 issues. So basically, chromosomal abnormalities have been found. That is, you don't have to learn the exact numbers, but yeah, when they found chromosomal problems, they were very sure that it's a tumor only. It's not some random tissue. It's a tumor because genetic problems are there. Okay, so Oma means it's a benign tumor. What is this hamartoma? Hamara. Why did I call it Hamara? Because please remember, there is a haphazard proliferation. There is a haphazard proliferation of which tissue? It's a Hamara tissue, native tissue. It is a haphazard proliferation of native or indigenous tissue. Of native or indigenous tissue. So now, well, having said that, let me give you the example. I gave you the example of pulmonary hamartoma. What are the things in the lungs? Lungs have trachea, bronchi, bronchioles, alveoli. We all know this. Does lung also have cartilage? Can you see a beautiful cluster of cartilage out here? I hope everyone can appreciate it well. There's a beautiful cluster of cartilage. So there's haphazard proliferation of cartilage. In simple words, there is haphazard proliferation of cartilage. Can I call it a pulmonary chondroma in that case because only cartilage is arising? Can I also call it a chondroma? Yes, I can. And please remember that is cartilage already a part of the lungs? Of course, trachea and all these have cartilage. Cartilage is anyway a part of the lungs. So cartilage is anyway a native Hamara tissue only. It's just becoming a little more. Whatever you have, that is becoming a little more. That is what you understand by the hamartoma. Okay, now having said that, if hamartoma was all Hamara tissue, you next need to know what is a choristoma. Choristoma is chori tissue, which means it is going to be ectopic tissue. Means the first question, is choristoma, Oma word making any sense? Is it a tumor? No, this is not a tumor. Forget benign or malignant. It is not a tumor only. It has nothing to do with the neoplasia chapter. It is an ectopic tissue, and let me explain it with the help of an example. For example, if this is the stomach, and in the stomach, I say over here, there is a little bit of pancreatic tissue in the stomach wall. Is it the stomach's own tissue, or is it an ectopic tissue? Of course, stomach is not supposed to have pancreas. If stomach is having pancreatic tissue, even if it is little bit, it is an ectopic tissue. Ectopic means it's a chorika tissue. So in the exam, always remember, in hamartoma, they will always mention there is some native hamara tissue proliferating. In choristoma, they will talk about some chorika ectopic tissue proliferating. I hope everyone is clear with this, because with this we wrap up all the introductory section of neoplasia. And what do we begin with next? The next part we start with is the features of neoplasia.